Hi, everyone. We'll get started in 30 seconds. Welcome, everyone, to this month's edition of MGB Global Health Rounds. We're delighted today to have the team from Pivot and Pivot Science with us. My name is Dr. Joe Radigan. I'd like to introduce, we have three speakers. Dr. Matthew Bonds. Matt holds a PhD in economics and ecology from the University of Georgia. He is an associate professor of global health and social medicine at Harvard Medical School, and he's the co-founder and scientific director of Pivot, which we'll hear a lot more about today. His research focuses on the ecology of poverty and economic development and the science of implementing global health delivery systems. Pivot works with the Madagascar government to establish a district-level model health system for over 200,000 people. With novel data systems at all levels of care, this partnership is pioneering a new science of health system transformation. His work has been supported by the MGH International Center, the James S. McDonald Foundation, and the Malago Foundation. Dr. Bonds is joined by Dr. Karen Finnegan. Dr. Finnegan has a PhD from the Bloomberg School of Johns Hopkins University, and she's a research associate at Harvard Medical School and managing director of Pivot Science. You're also joined by Dr. Hobisoa Razanadranaivo. Apologies, Ubi. Ubi is the population impact research manager at Pivot, where she works to measure the impacts of the health system intervention on the population in Madagascar. And the team today is going to be talking about, does strengthening health systems reduce mortality rates? A decade of longitudinal results from Madagascar. Thanks for joining us.
Thank you, Joe. Can you hear me okay?
Yes.
Great, thank you. And thanks everyone thanks for inviting me, thanks for inviting us, and thanks for joining this call early in the morning. First, our requisite title slide. I'll move past this, disclosures. Before I move on, I also just want to acknowledge that a lot of people are involved in this research. As always, this is really just a subset of our research team who've all contributed directly to what we're presenting today. But of course, it's the entire staff, the Ministry of Health, our many partners, really hundreds of people, if not thousands of people involved in what we're presenting today. So quick outline, I'm going to present an intro and background and some results on our mortality trends in Madagascar. Karen will present a program evaluation of the health system strengthening in Madagascar, and Ubi will talk about expansion and new baseline data that she has recently analyzed. This talk is, at its core, this is about the relationship between healthcare and population health. The global development community thinks in terms of population health. The sustainable development goals, all the health-related development goals, or at least most of them, are in terms of population health, like universal health coverage, like under 5 mortality, neonatal mortality, maternal mortality. And so it's very important that we understand when we're in the healthcare delivery business what our relationship is to that. It's also important for the obvious reasons that the aim is to save lives and improve livelihoods, and being able to measure that, not just for our patients, but for the populations, is central to how we approach the health equity mandate. So, and for some, there's sort of a conventional wisdom about this, which is we know what to do as physicians, clinicians, medical practitioners. We just have to do it, right? This is the no-do gap. The technologies exist. And the evidence for that is actually overwhelming, right? The evidence for individual maternal and child health interventions show reductions in mortality. There's so much of this, we all know them: malaria treatment, antibiotics, hand washing, ANC, and on and on. And there's so many studies that have shown within individual analyses that they save lives, that people have aggregated that data. And there's actually quite a big literature on what would happen if we achieved universal health coverage of essential medicine. So for example, in 2003, Jones et al. Estimated that if we implemented all of the known technologies that should be available to the world, especially in underdeveloped countries, we could reduce maternal and child under 5 deaths by 90%. 10 years later, Freiberg et al., using the LiveSaves tool, had a similar estimate. The LiveSaves tool is it's a model aggregating the interventions, and they found that if we could avert 85% of maternal and child deaths by targeted health system strengthening initiatives. That's what we expect. That's our intuition. That's why we promote healthcare. The evidence from integrated programs that actually do these maternal health interventions in the context of a health system to last outside of just a specific research study, have very different results. Bryce et al. Analyzed the Accelerated Child Survival and Development Program in 3 districts in Benin, Ghana, and Mali, and found that the effects on under 5 mortality in the intervention areas was actually not as great as the comparison areas. They found no impact. Right? This is UNICEF-funded study. This is the kind of thing that legitimately gets out there, and people raise questions about the effectiveness of international aid. Our friends at Partners in Health in Rwanda, Karen and I were involved in this work, found under 5 mortality dropped actually pretty significantly in southern Kayonza and Karehe compared to other rural areas, and that was a pretty strong result. But it has lots of asterisks. As you can see in 2005, those wide confidence intervals, there really wasn't a true baseline. That baseline is collected from previously collected demographic and health survey data, and so very low sample size reduces confidence. And of course, there's a lot of other things going on in Rwanda at the time, and we don't have results for after that. So it's a really strong signal, isn't fully conclusive. Friends, I don't know if many of you know Integrated Health. They're also kindred spirits, or they're part of the Community Health Impact Coalition, which is kind of like the new version of the Praxis Network of Partners in Health. They have a very similar kind of model, very inspired by the Partners in Health approach. Community health workers, health center intervention, health system strengthening intervention. They show in this red line, you can see here that their under 5 mortality dropped it started off lower than the rest of Togo, and it dropped at a similar rate as Togo. So they found, though their programs had worked, as far as though they were successful in implementing their programs, they had no signal on under 5 mortality. And then a slightly more well-known result is by the folks at Muso, also kind of products of this space. Ari Johnson was here at Harvard Medical School. They had actually sort of the opposite results. They found under 5 mortality dropping by almost 85% in 2 years in Bamako, Mali. That's like so big that that also raises questions, because under 5 mortality is collected over 5-year moving average, is essentially a 5-year moving average. You use a 5-year birth history. It takes 5 years to fully reduce that. So an 85% reduction in 2 years is actually probably too much than you could attribute to an intervention within those 2 years. So something else must be going on, demographic change, et cetera. So these are all suggestive. They're not particularly conclusive. They have data issues. And I should say, this is, to my mind, these are sort of gold standard interventions. These are the organizations that are doing really strong work, maybe among the best work in community-based health system interventions. And then notoriously, there's the Millennium Villages Project. If any of you are familiar with them, their goal is to reach these, at the time, Millennium Development Goals. They had an integrated approach, includes health interventions, but also other kinds of economic development programs like agriculture. And they found actually pretty convincing 31% reduction under 5 mortality, and published a nice article in the Lancet, and there was a lot of visibility around this. It's pretty exciting. These are interventions in 9 different sites across sub-Saharan Africa. But then, and that actually moved the needle for a moment. There was a moment when people said, oh, this is a really nice result, something we hadn't seen before. But then some comments came on board that people felt like they didn't make the right conclusions from those studies. And in fact, if you annualized that reduction over the 4-year period in which they observed those reductions and compared that to the country's national trends for those 4 years, they actually were less than the national trends. And so they corrected their paper, and it's become a little bit of a thorn in the space of all of us who worry about this. I should say that I don't think anyone actually made an issue with their findings of 32% reduction, and that was faster than their comparison districts, just less than the national trend. So it just raises questions. They didn't do a full retraction either, which is important to acknowledge. They changed their conclusions. So all this is to say, we have a lot of confusion around population mortality impacts of health system interventions, a lot. And I would say it's actually one of the great paradoxes of global health, which is that there's overwhelming evidence that individual maternal and child health interventions should reduce mortality, neonatal mortality, infant mortality, child mortality. There's actually not a lot of evidence of how those programs have worked on that. All of the evidence is loaded with lots of asterisks and is largely inconclusive. So what's going on? So one question is this an issue of limitations of implementation and translation? Some people call this fidelity. The programs are not being done. This is actually what Bryce et al. had supposed. It doesn't look like these programs are actually being implemented. There's another thing that's related to this, which isn't really an issue of fidelity, which is that the process of implementing can be very different than what a study design might be. It might take longer. There's more heterogeneity. It's not really a fidelity of the implementation, but a fidelity of a particular research design. And that's very different. And so those things can take longer. They're less predictable. You're dealing with heterogeneity over space and different actors. Could this be limited? So that's one explanation. That's just the challenges of doing this. Another is the limitations of medicine. Maybe mortality is mostly driven by social and environmental determinants, and that we are vastly overstating the power of medicine to address population health. Or maybe the question is the issues of the science itself, right? Missing counterfactuals. Even if you have counterfactuals, they have confounding effects. Your data might have confounding effects, which is what the accusation of Musso has. They were working in Bamako. A lot of demographic changes the inference you can make, or other data issues like small sample size. Short time series is really, really important for mortality rates, which inherently the actual indicators lag behind, and low data quality. Those are the kinds of questions. So what's going on? Our feeling about this, there's actually a big, a growing conventional wisdom that mortality is such a poor guide to any of this work that we shouldn't even be measuring it. It's so challenging. And it's true that there is no gold standard for measuring a health system intervention on a population for all kinds of reasons. We don't feel that way. At Pivot, we do feel like the fact is our aims are to save lives. The aims of the health systems, and the guidance is around population health, and we want to at least know what explains the challenges in these results. So one approach is having model systems. Well, what we do at Pivot isn't radically different in approach than, in fact, we learned directly from Partners in Health, in particular Partners in Health in Rwanda. The interventions are not radically different. In fact, they aspire to be as effective as a lot of our peer organizations. But we take the data, the lessons of the data from those programs really seriously. So the exciting thing about model systems and throughout sciences for everyone who's been involved in model systems is they're actually really important if we're trying to understand a system. And in these cases, the system effects are of fundamental importance. And one thing I'll mention, Karen told me not to talk too much about complexity. It's like my favorite topic, but it really is important to acknowledge that these are complex systems, that the whole really is different than the sum of the parts. It really does matter that we study this system. So that's our aim. So this is Madagascar. We work in Finnegan district in the southeastern region. We work just like our peers, just like partners in health, just like those we've been learning from. Some of you probably are on the call. We work at the community level, 400 community health workers in the Finnegan district, 21 primary care health centers, 1 district hospital. And all the staff, stuff, and systems and space approach that folks are associated with health system strengthening in our environment. I'd like to talk more about the health intervention. I don't have time for this talk, so that'll have to be another talk when I get to the data as fast as we can. So it's important also to note that in addition to those 4 S's, there's the science. And in the science for today's talk, there's 3 main sources of data. When we talk about household surveys are one, health management information systems is another really important source of information, of course, and geographic information systems. And for most of the work that we do, we try to take all of the data that we can to understand what's going on in a particular intervention at the population level. So our household survey is particularly exciting for a number of reasons. One is it's district representative. These are representative of the population with a true baseline inside and outside of the initial catchment area. It's longitudinal, so we're tracking the same households over time. So major shifts in demography are not going to distort our results of the impacts on the programs for the families that were there when we started. It's standardized. We don't collect the data. The National Institute of Statistics collects the data, the same folks who collect the data for their Millennium Development Tracks or the DHS. It's quasi-experimental design, as I mentioned before, inside and outside a catchment area. And this is for the long term. We've been doing it from the very beginning, starting in 2014. It's now been about 10 years, and we're going to continue doing it as long as we can. So I didn't say this, but there are about 7,000 individuals in this data set. So quickly, before we move on to the other speakers, I'll just review mortality. When you look at the mortality results, here are our mortality results. I'm showing you 2. One's for the country of Madagascar and one's for a Finnegan district. And if you look at this, your first reaction, I suspect, is, that's not very interesting. That looks like the same results we have everywhere. And therefore, I wonder if these kinds of programs are really lowering mortality rates. That really is what the normal conclusion is. That's one conclusion. Another conclusion I'd point out that's different about this and other studies is that Madagascar as a country, their under 5 infant and neonatal mortalities have not been, sadly, they haven't been going down, which is not the case for all of the other studies that I've mentioned. If you look at the differences, this is just representing those twos as that this is a representation of the top row, but in terms of the difference from the beginning. And what you'll see is the same thing. These are basically the same outcomes. It looks like a nice signal on under 5 mortality, but not one on infant neonatal. But that's actually not the story. And by the way, if you were to look at a district level, like Bryce et al. Did, or like the Partners in Health Gang did, this is similar to what you might interpret. But we had an initial intervention area in the district, and then a comparison area in the same district in which we slowly rolled out. And there, the signals are really different. This is here you can see the mortality rates and in the intervention area and the comparison areas. The comparison area is this orange dot, the rest of the district. The green is the intervention area. And if you want to see the differences there, you get a much stronger story. What's happening here, you can see, is that in the initial intervention area where we had where we rolled out programs in population of around 60,000 people, actually all mortality, under 5 infant and neonatal mortality dropped in every case. Unfortunately, outside of this intervention area, They were rising. Rising like, in fact, the rest of the country, mortality rates are rising. And so this is actually a really strong signal and a really compelling one. And so we want to learn more. So far the lessons here are that improving population health is a key objective for health systems. No gold standard for evaluating such impacts. This model system combines many data sources, which is really important. And the first 10 years show decreasing trends in child mortality in a context that actually was not otherwise decreasing, in fact, was increasing child mortality. But there's a lot of questions remain. If you're looking at this, you should think, I hope you would think, that's genuinely interesting. I have a lot of questions. So let's look at some more data. So for that, I'll introduce Karen Finnegan, who Joe did a nice introduction of. I'll just add that she was the head of monitoring and evaluation for Partners in Health when I was there in Rwanda some 15 years ago now. She was the associate director of monitoring and evaluation, and she's been helping us on the data side from the very beginning of Pivot. So go ahead, Karen.
Thanks, Matt. So I want to start by talking just a little bit more about the intervention. So what did Pivot actually do within Finnegan District? And it started at the community health level, and Matt's driving the slide, so he's going to keep advancing to take us through the various levels of the intervention. So there are community health workers who are providing care, especially for children under 5 and pregnant women at the community level. There's an intervention at all 21 facilities, all health centers, primary care health centers across the district. And this includes notably the removal of user fees for people who come to seek primary care services, as well as advanced care. There are infrastructure improvements. There are human resources for health, so making sure facilities are staffed. And then there's an investment in data systems to improve the amount and quality of data that are being collected as part of the health system. There's a special focus on maternal and reproductive health, which includes maternal waiting homes where women can stay prior to giving birth. And then there's a system of referrals as well as ambulances to support travel from primary care health centers to the district hospital. And then on the next slide, we're going to talk about the health management information system. So as Matt said, in order to understand these changes in mortality, we need to create a plausible argument that we saw changes in the health system and in intervention coverage. The Health Management Information System is a system of data that's collected routinely by the public health system, where facilities report on visits that were occurring at their health center. These data are aggregated and then reported on a monthly basis up into the national system. So this is like number of children who are diagnosed with malaria or number of facility deliveries. And this is really the best source of information for routinely provided care at health centers and at the district hospital. When we look at that data, yep, that's right. When we look at that data, we're able to see what happened in terms of consultation visits at the health center. This table is looking at outpatient visits at 21 health facilities across Finnegan District. And I should note these are public sector health facilities. So Pivot was strengthening the public health system. We're looking at outpatient visits for all ages as well as children under 5, and then specific maternal care services. These are visits per capita. And you can see at baseline, there are no real differences, no significant differences between the Pivot initial intervention area and the rest of district. Then we see, if you click again, Matt, that we see that there is an impact of this facility level health system strengthening. So when we remove user fees and when there are investments in health facilities, we see a significant increase in per capita utilization across all sorts of care seeking. So a near a tripling in outpatient visits of all ages and a more than 100% increase in outpatient visits as well as maternal care services. We then look at whether or not there's a change due to program-specific health system strengthening support. And this is either community health or maternal care services. And here we are seeing significant changes. I want to draw your attention notably to the maternal care services, where we're seeing an increase, that when we implement these maternal waiting homes, as well as supportive kits and other services targeted at pregnant women, we see an increase in the per capita utilization for prenatal care, first visit and fourth visit, as well as for deliveries, and a slightly less significant increase for postnatal care. So that's starting to tell the story of what's going on at health centers, but we're interested in how do these visits translate in terms of population coverage. And so we return again to the longitudinal cohort that Matt was talking about. Here I have a series of 4 indicators where we're looking at population coverage change from 2014 to 2023. And you can see even at a glance, we're going for all 4 indicators: antenatal care, births at the public health center, care seeking for illness for kids under 5, and then care seeking for all ages. We're going from mostly red to mostly green. So we are seeing that there is an increase in coverage for these essential care services, but we see geographic disparities. That's right, Matt, thanks. When we look at this data in a model, we're able to quantify the change due to the same metrics that we were looking at in the previous table when we're looking at visits in the HMIS system. Again, we see no significant differences in baseline between the intervention and the rest of district area, but we do see interesting results in terms of the facility level health system strengthening intervention and the program specific support. So, for example, we see that there is a significant increase in all recommended vaccine coverage among children 12 to 23 months. And again, we see significant increases in antenatal care, in births delivered at a public health center, and in postnatal care when those maternal health programs are implemented at health facilities. You can see that we're starting to create a consistent story where we're seeing an increase in visits as reported by the Health Management Information System. We're seeing an increase in coverage when we do a population health survey. But as those maps showed, we see this interesting gradient across geography. And so Felina Ihantamalala, who is a postdoc at Harvard Medical School, as well as Pivot's Geographic Equity Research Manager, has led work around understanding the geography of Ifanadine District. You can see her in the striped shirt in the photo on the left. She combined methods where a team in an office used remote sensing of OpenStreetMap images of Ifanadine District, and combined with a team who went out into the field to collect information on travel time to understand the geography of the place. And we see how we've used some of that work in the next slide. So on the left, you see a map that's looking at average per capita consultations among children under 5. And the light gray line looks at consultations with a community health worker. The darker line looks at public health center consultations. And what you see is that there is an incredible gradient across distance. So from 0 to 20 kilometers, there's a sharp decline in public health center consultations for children under 5. Children under 5 are not being brought or not able to go for care at health centers. But we see an inverse amongst community health workers, where those who are farther away from the health center are able to seek more care, increasing their per capita consultations amongst community health workers. When we think about what impact that has on care seeking for illness at any public provider, community health worker or health center, we can see that there is a meaningful change from 2014 to 2023. The graph on the left is showing us that in the red line, or the brown line, in 2014, we saw that there was a distance decay in care seeking for illness in the household survey. So you can see that as distance from the health center increases, we see a decrease in care seeking for children under 5. And then in 2023, the green line, we can see that with the deployment of the community health program, we're seeing a flatlining. So essentially, there's no distance gradient in ability to seek care amongst children under 5. So that is creating a story and helping us understand how if changes in mortality have been consistent with what other data sources or other indicators are telling us. And so we see that the changes in mortality are consistent with the increased visits at health facilities, with improved coverage of maternal and child health interventions from a population survey. And we see a reduction in geographic disparities with the implementation of a community health worker program. However, questions remain. And there are questions around, is this replicable at a larger scale? We've tested things in one district, but are we able to see a consistent message if we think about expansion beyond Ifanadine? There are also questions around whether we can attribute statistically these changes in mortality to the intervention. And of course, there also remain questions around what other drivers do we need to consider thinking about changes in health and care seeking. And so not just quantitatively, but are there qualitative research methods from fields of medical anthropology, from sociology, and from qualitative research that we can apply to understanding these quantitative changes that we're seeing. Pivot honed this model through an iterative process in Ifanadine district, which had a population of about 200,000 across 21 health centers, 1 district hospital, and almost 200 community health posts. And now they're working toward expansion at the invitation of the Ministry of Public Health of Madagascar. So what we did in Ifanadine, can we see that in the other districts of Vatovavi region, Nosy Varika and Mananzari? This means taking a population of 200,000 to 1 million, from 21 health centers to 87, and from 195 community health posts to more than 700. You'll also note that the brown squiggle on the side of that map is a canal. And so Matt was showing the photo. It's a significantly different geography. So we're going from a mountainous region or district all the way to the sea. And that includes navigating the canal. Ubi, if you go back, Ubi is going, can you go back to the photo, Matt? Ubi is going to talk about the baseline survey that we did prior to expansion, but I want to start by complimenting Joe's introduction with just a little more detail. So Hobisoa Razanadranaivo joined Pivot a little more than 2 years ago. She's a medical doctor by training and came to us from Institut Pasteur of Madagascar, where she was a research coordinator. She is our population impact research manager, and her first task when joining us was to oversee baseline data collection across Vatovavi region. She's now leading that analysis and is working on completing her master's in public health. And so with that introduction, I'll turn it over to Ubi. I'll note she's joining us from Madagascar, and her Wi-Fi is a little spotty, so she's going to try to turn her camera on, but may need to turn it off if there are some internet challenges. Thanks, Ubi.
Thank you, Karen. So about the baseline, the data collection was conducted in 2023 by surveying around 5,000 households in the 3 districts of the region, including the initial intervention district. The surveyed households are distributed across the 3 districts represented by the orange dot in the map that included more than 12,000 children, 5,000 women, almost 5,000 men, and more than 1,000 of seniors. In this survey, we used questionnaires of DHS as demographic and health survey to assess socioeconomic and health conditions of the population. About socioeconomic characteristics, here we have the data for Madagascar based on the DHS results in 2021 and the results of our study in Fatuvav region. We can see that population in the region lives within a precarious socioeconomic conditions with a very limited access to safe drinking water, electricity, and improved sanitation, with particularly a very high practice of open defecation. About the mortality, compared with the DHS results in Madagascar, the region is part of those having the highest under 5 mortality, 100 per 1,000 live births versus 75 in the country. Maternal mortality is also very high, 695 per 100,000 live births, exceeding twice the national target by 2030. We have here the indicators of health coverage in maternal and child health and its percentage rates. The bar plot represents the data for the whole region, and each circle, according to the different colors, represents each district. So the orange dot is for Ifanadina, which is the initial intervention district. The green for Mananzari, which is the capital of the region, and the blue for Nusivarkia, the third district. For the maternal health, we can see particularly a very low rate of delivery in health facility, less than 30% for the 3 districts. And for the child health, we can see a low vaccination rate for all vaccinations recommended in the country. And in case of respiratory infection or fever or diarrhea, care seeking at public provider is higher in the initial intervention district compared with the 2 other districts. In this graph, we have distributed the healthcare coverage indicators according to wealth quintiles. So the dot in pink represents the poorest and the blue one the richest. And the more the distance between the 2 dots is large, the more the inequality is high. So what we see here is that there is inequality in favor of the rich for almost all of the health coverage indicators in maternal and child health. For the geographic coverage, we have here again the map of the region with the road accessible by car and health centers. On the map, we distributed care-seeking for illness at public provider for children under 5 in the left and for people 5 years and older in the right. And we use colors from red to green as proportion of care-seeking increase. So the more red is for the lowest rate and the more green is for the highest rate. We can see that care seeking is higher around the main road and in areas accessible and closer to health centers, particularly in the initial intervention district. We can see the same distribution in the 2 other districts, but more areas are not covered yet. We have seen earlier that delivery at health facility is low at the region. So to look at the geographic coverage, we distributed data in 5 quintiles, and we use the same colors as the previous map, that is red to green. And we can see that we have also the highest rate around the main road and in areas accessible and closer to health centers. When looking at the main barriers to care, in the 2 districts, financial barriers come out on top, while in the district of the NGOs and initial intervention, where there is removal fees in public health structures, Financial barriers represent only a teeny proportion, and most people reported no barriers to care. For this study, we learned that baseline differences in wealth, health, and care seeking exist in the Vaduvav region, and this data enable us to answer important questions before intervention rollout. Health system strengthening activities differ from district to district, and maternal and child health care are the priority programs.
Thanks, Ubi. It's my job here to wrap this up. So before we go to questions, first we'll acknowledge various funding sources, of course, in addition to all of our collaborators, including Harvard Medical School. In terms of total summary messages, I would like to highlight a couple main themes. The first is that the question of how to translate healthcare delivery to population health, that's becoming better known around the health coverage and UHC question. It's much thornier around the mortality question, which is the most important of the questions. The results that we have are very suggestive of impacts on mortality, but importantly, the key to understanding that is understanding the evolution of the health system intervention over time, so we can compare different areas, and also corroborating that with population health service indicators like the coverage, along with consultation information, to combine what you end up seeing as a coherent story where coverage is consultations have increased significantly, every form of consultation, healthcare coverage, every form of coverage has increased over time. Geographic barriers have reduced, and you can see the geographic barriers are reduced from both the clinical consultation data as well as the healthcare coverage data. And then finally, I'd like to say that Finnegan has long been the poorest of the three regions of the three districts that Ubi shared, and it's intriguing to show that here is a district that had indicators that were far worse than the rest of the region, and over time now is almost even on maternal health indicators, and is actually doing much better on the child health indicators. So I think that for that, I think that's the answer. Thank you. We'll take questions.
Thanks so much, Matt, Karen, and Ubi. I'm going to turn it over to Serena to do the Q&A. Just a quick question, and I think this was on one of your slides, but I missed it. What are the leading causes of mortality for the under fives?
It's the same. It's the same in Madagascar as in most of sub-Saharan Africa. It's malaria, diarrhea, and respiratory illness.
Great, thanks.
Actually,
but also worth saying, there's there's other issues like measles. We've had measles outbreaks in Madagascar, other vaccine preventable illnesses. Sorry, I heard someone's voice.
I was going to follow right in on Joe's question. Again, really phenomenal presentation. And my question is about tuberculosis. I mean, as you know, there are high mortality rates in children under 5 from tuberculosis. Do you measure like specific inputs at the health centers, like proportion of young children who are household contacts who receive TB preventative therapy, for example, and then like rates of completion of TB preventative therapy, so that you could measure like for each specific disease? I mean, I'm assuming TB is one of the top 10 causes. Do you ever look at like each individual cause to sort of give yourself a report card on that and think about specific interventions to improve those?
This is for Karen.
We do. So yes, we track tuberculosis outcomes as part of a TB program. Community health workers do suspected case detection based on history of cough, and then refer to the district hospital where there's gene expert for testing of tuberculosis. In addition, malnutrition is one of the drivers of morbidity and mortality, especially among children under 5. And so there's a malnutrition program that where we track outcomes of inpatient as well as outpatient malnutrition. So we've presented on a few different data sources, but there's really a robust monitoring and evaluation system around various clinical programs that underlies this as well, to help us understand how programs are being implemented and how they address disease burden. One of the things that we weren't able to get into because of time, as part of the 2023 household survey and the 2021 cohort, we collected dried blood spot data from participants, and we are doing analysis in collaboration with the Institut Pasteur of Madagascar of those samples to understand exposure and disease burden for pathogens that may not be easily identifiable through symptoms, to help us better understand the underlying disease burden and exposure.
So in terms of working with all these health systems, I know you're working in the public systems. Are you able to actually kind of drill down and look at what proportion of household contacts are receiving TB preventative therapy? Or if are you able to sort of say, well, boy, this trial showed that giving the whole household food, if they have someone in the household, are you able to kind of implement those small, are you able to work in collaboration and sort of say, wow, look at this research study found this, let's make that small improvement here? Or is that too, wow, that sounds really exciting.
Yeah, I would say that it's ongoing and is been part of the iterative process, I think, in order to create a model, but also to respond to the data. And the tuberculosis program, we've had some guidance from Michael Rich, who's one of the co-founders of Pivot, and a world-renowned tuberculosis expert. The tuberculosis program is largely implemented by the Ministry of Public Health, and we follow national guidelines, but community health workers with Pivot support are able to do contact tracing and program support.
That's amazing. Yeah, I feel like I must email you because so few programs have this amazing organization, data measurement. Just your systems and your programs are amazing, and then also done in such a collaborative way with the Ministry of Health. It's just beautiful. So if I don't see any other questions, so I'm happy to ask you questions all day. So
There's one in the chat, Serena.
Thank you. I didn't see it in the Q&A from Amir. Thank you for the excellent presentation. One question. It sounds like in addition to implementing the population health interventions, you also implemented enhanced data collection in the intervention districts. How can you tease out the effect of the intervention compared with the different data collection? Is it possible that some of the observed changes may be rooted in differences in data collection? What a great question, Amir.
That's a great question. That's also one, unfortunately, that I have to give you, Karen. Karen's our HMIS expert.
Yeah, it's a good question. I mean, part of the work that we've been doing is understanding how strengthening the data system may influence what we're seeing in the data system. And so it's part of the interesting opportunity around expansion, is thinking about how we can strengthen the data and understand what impact we might be having on what's being collected. It is part of why the triangulation between the HMIS and the cohort or the household survey are so important, because they're telling a consistent message. It helps strengthen the plausibility of the argument that it's not necessarily just that we're making reporting better. It is that there's also we're truly seeing an impact, because we're seeing change at the facility level, that's translating to coverage change at a population level that helps reinforce the facility data.
I'll add on the HMIS side of things. In some cases, if for example, with community health workers, the community health workers that we support have both support the implementation and they have support with the data. And we don't compare that data with data from community health workers that are not supported because the data quality is so much lower. On the other hand, from the very beginning, from the first years of Pivot's work in Madagascar, we collaborated with the Ministry of Health, the head of the region, which is where the monitoring evaluation for the district happens. And we supported 2 new employees at the level of the region for monitoring evaluation, and directly supported the monitoring evaluation systems for all of the health centers, even the ones that we weren't working in. And so that doesn't mean that all the data quality is the same, but it does mean that we were trying to address this issue by ensuring quality data as much as we could, in the same way that we have a baseline across the whole district, even for the interventions where we weren't working from. It's a legit consideration. It's one we put a lot of energy into.
I have another question, which I'm sure is on everyone's mind and is utterly depressing, but in terms of the US government's demolition of USAID and all global health programs, what will the impact of that be on the incredible work you're doing?
I'll start with that. So, this is like directly, so we don't get a lot of USAID. We have some USAID funding. We've actually intentionally not sought a lot of USAID funding just because we're still a young organization and it's just a huge burden to manage federal grants. And so we consciously have not been regulated by the US federal government. And so, and it's helped a lot, right? Because it does make our programs more nimble and more flexible. And so we're not hitting an initial cut. It has a huge influence on overall programs. USAID has a big impact on the entire health information system of Madagascar. They have a big impact on malaria coverage in Madagascar. The whole DHIS2 system, which is like the system for health management for HMIS across the country, which we use, that is where the data get aggregated, that has actually been led largely funded by USAID. The DHS, Demographic and Health Surveys of Madagascar, are funded by USAID. So there has implications throughout the entire country for what we can do, what data there exists, and what programs are necessary locally. And this includes like smartphones for community health workers. So all those are big impacts. I'm hoping that a question that you didn't ask, but I'm hoping that what we can do though is there are, in fact, legitimate reasons to be concerned about how resources are used to improve quality of healthcare. And not all interventions are the same, but also a lot of good interventions haven't been able to produce the kind of data that they would like to be able to produce for various reasons. And so what we're hoping we can do is shed light on the power of these kinds of programs when you have the right kind of data that even when at first glance you're not quite seeing the signal, you might have, in fact, it can be quite valuable. And in our case, they're helping drive the expansion more regionally.
Thank you for that. I wasn't sure if Karen was going to add, and I have a question from the Q&A. Karen, did you want to add to that, or are you?
I think as Matt so clearly articulated, one of the challenges is just around system shocks. And I think part of the USAID funding that has worked historically well in Madagascar has been around advocacy for policy change and understanding policy development, as well as medication and sort of supply chain support. And those are 2 big areas that remain, I think, in question as to how sort of national systems will coalesce around those 2 areas, in addition to specific disease programs.
Our executive director was talking to us, I guess it was last week, and she had highlighted there's a $13 million gap in funding for malaria meds in Madagascar. So, which for a country like Madagascar, which in total is spending about $20 per capita on healthcare, it's a lot. It can't just find that wherever it wants,
So I have another question from our chat from Ruma. Thanks again for an excellent presentation. I think we are all honestly in awe. This is an amazing presentation. I am interested in your interventions at the hospital level and impacts on maternal and neonatal mortality. Can you speak more about this? Another really great question.
I'll try. So unfortunately, we should have brought. Unfortunately, Ubi was hired in the past couple of years to do population-based research. She wasn't hired as a physician, even though she is a physician. So we don't actually have one of our physicians here to talk, who works at the hospital here, unfortunately. I'll do my best. So one thing we didn't show, which is actually probably our most significant result, is that maternal mortality has been cut in half. So it was at the beginning in 2014, it was roughly 1 in 14 women would die. 1 in 14 women would die in childbirth over the course of their lifetime. That's the lifetime maternal mortality rate. That's been cut, which is about the highest for the country, and if that were a national figure, highest for the world. That was over after just several years, that started dropping to nearly half, and it dropped so much that we haven't published it because we were really suspicious. We wondered if this was an artifact of the data of the low sample size. So we've actually haven't included that in any of our information. And Ann Miller, who might be on the line, has kind of obsessed over this. And then recently, amazingly, because we had this new baseline, so we had the longitudinal cohort, which is extended for 10 years, but also we have a new baseline for the region, which includes additional, or a whole new random selection of households. And we did that importantly because we wanted to see how does our initial cohort compare to the representative of the population. That was a critical question that we've been wondering for now a decade. And it turned out that was almost exactly the same. So maternal mortality has dropped to about half. In our district and sustained. And the question is, why is that happening? So we're seeing results on like antenatal care that has come up in expansion of antenatal care, some expansion in deliveries in informal health system, although that's not as high as we would like it. At the hospital level, there's two major things going on. There's a referral system, so an ambulance program that can take pregnant women for whom there are maternal waiting homes at the health centers. I think it was Karen who has already mentioned that. And at the hospital, we pay for the surgeon. So there's a surgical ward. They can do C-sections. We actually haven't, and of course, there's a maternity ward at the hospital. We have not seen major increases in C-sections. So I'm not going to suggest that that's been saving all the lives. I don't know if that answers your question. There's probably more that a physician could answer around maternal care at the hospital.
I think that was a wonderful answer. And Ann Miller has given you your exact numbers, a decrease from 1,044 to 512 per 100,000. I mean, that's like amazing life-saving work. So we have 2 more minutes, but we have one more question. So it's probably one you can answer pretty fast. So Willie Ann says, is there any thinking about alternatives to DHS? That is a huge loss, as DHS data underpins so much research, demonstrable results, and therefore advocacy. So I think that'll be our last question to you before we end the session.
Should we see if Hubi wants to answer that? And if she doesn't, Karen might. Hubi, do you want to say anything about the future of the DHS and what the alternatives are?
So are you asking about the future of DHS?
Yeah, so if DHS is not going to be collected because USAID is not funding it, what's Madagascar going to do? Do you know?
I'm not sure, Karen. Can you answer that?
Yeah. Matt's asking you to get out your crystal ball. It's a hard question. So the MIX, the Multiple Indicator Cluster Survey, which is UNICEF funded, is being collected in Madagascar now. And so that is a good source of very similar data to the DHS. I don't know what the future is. And as Matt's slide where he talked about the results of PIH, MUSO, and Integrate demonstrated, understanding specific interventions in light of national trends is so important to establishing a story around whether something is plausible. And so without a national data source, it's really, there's a lack of information. we're talking now in Pivot around, we've done the baseline in 2023. What's the future of data collection look like for us in terms of another household survey, given a lack of national data? I think we will sort of globally, organizations will need to rely on smaller studies and thinking about what results are saying, increased pooling of results and data across organizations. And I hope with the upcoming end of the Sustainable Development Goals, there is some sort of push to collect national data, but my crystal ball is also murky.
Well, it is 9:01. I just want to end by, I'm speechless. This is incredible work you're doing. And I got to second what Matt said. I feel like data is advocacy, right? And the fact that you're both providing incredible care and also collecting data is incredibly powerful at a very, very challenging time. So, Joe, I'll give you the last word of congratulations to them.
And thanks, Serena. No, thanks so much, Matt, Karen, and Ubi. That's really such inspiring work, and you all have been at it such a long time. It's really impressive, and thanks so much for sharing it with us today.
Thanks for having us. It was a pleasure. This paper is in review. This is the first time we've presented it. So thank you for your feedback.
And maybe when your paper is published, talk to a journalist to get it in the New York Times.
Yeah. Thank you for the suggestion.
So long, everyone. Thank you.
Bye.
Bye-bye.